come in often is in the follow-up to an acute stroke, is looking to see someone through their journey whilst they're in hospital and deal with their questions and queries then. Looking at how we stop another stroke from happening in that immediate time after the acute event, and then also to look to reassure people that they can and we can do everything possible to prevent further events from happening, whilst dealing with everything else that we've heard today, trying to rehabilitate, trying to access information, trying to access help, and trying to access the support. So the main areas of sort of intervening from a medical perspective are around what we call secondary prevention. You've had the acute stroke. In your case, it was a subarachnoid hemorrhage. Yeah. And we look after subarachnoid hemorrhages in the same way we look after a bleed in the brain or a blockage or a clot on the acute stroke units, because we recognise that the disability and the loss of independence and the recovery from that setback is very similar. And therefore the immediate treatment might be very different. In your case it was surgery, in your case it was very much an induced coma to manage other complications around the stroke. But overall I think people are still worried about what happens next, will it happen again? Main thing, and you mentioned it here, was fantastic around the blood pressure management, and our follow-up after people have left the hospital is often around checking that the message about what you can do to help yourself or try and prevent another stroke has really sunk in, but also the opportunity to do it. So how do you get a blood pressure recording? Do you have to come into the surgery? Do you buy yourself a machine? How often does it need to be checked? Who do we check it with? Do we check it with a GP, or can we come back to you as our stroke physician? And we say, well, we'll see you again sort of 6 to 8 weeks after the acute stroke, but the country as a whole has very different methods of following up stroke patients. And the Stroke Association now do 6-month follow-ups, and some regions have contracted the Stroke Association to do those follow-ups. And those follow-ups will incorporate a number of things like the blood pressure, but also signposting, addressing people's concerns. But going back to the blood pressure area, it's really giving people the opportunity, whereas before they've been told your blood pressure's okay, is arming them with what is a safer figure, what do we know from the studies, what do we know from the evidence will reduce your risk of having another stroke, of a heart attack, etc. Because the population we're talking about, and particularly in this geographical area, is an older population. Felixstowe has a higher incidence of stroke, I would say, compared to other parts of East Suffolk. And we need to try and support people to manage some of the sort of chronic problems. You talked about the weight issue that you had prior to the stroke. Now, that for a subarachnoid hemorrhage might be something that was a problem, but not directly an influence to why you had an aneurysm in the first place. But what we do know is that blood pressure and weight are closely related, and so trying to access activity and cardiovascular activity and explain to people that it's not only just the medication that will help lower blood pressure, but it's also the physical activity that will do that. So the cardiovascular activity, how do you access 40 minutes of an exercise? Do you have the means to do that? Do you have the access to do that? Now, we can't necessarily do that in hospital, but we often rely on carers and individuals to seek that out. And at that 6-month, 8-week follow-up and the 6-month follow-up, the opportunity to say, has that happened? What else do you need to make that happen? So we do measure weight, we do measure blood pressure, and giving people targets. So, and it's got to be tailored to the individual. So if someone's had, for example, a stroke and they've got diabetes and maybe heart disease, then we will tailor the blood pressure that is right for them. If they've got a narrowing in an artery in the neck that requires them to run a little bit of a higher blood pressure to get the blood up to the brain, then we will tailor. So it's very much tailored to the individual, but we still abide by the sort of general national guidelines, which would be looking, for example, for most stroke patients to try and get a blood pressure less than 130/80. And now I'm advocating home blood pressure monitoring, sometimes the GP surgery to provide the sort of average blood pressure monitoring. And then come back to me or come back to my colleagues or go to the GP to give that feedback, because it then becomes something very proactive and responsive to your needs. And as I say, it's a bit of medication, but predominantly lifestyle changes. So often cardiovascular exercise and weight loss are the things that we're coming up with. I suppose the next big area of prevention is about what kind of medication you take immediately, and people talk a lot about aspirin and the benefits of aspirin, and what we often say to the GPs, for example, if one of our GPs was seeing someone today who they thought had had a stroke, perhaps from mild symptoms that they described a week ago, is get them started on aspirin now, because that initial first 2 weeks after an event is the specific danger area from all the studies, and aspirin will have the most benefit in reducing your risk of another stroke. And so, provided you haven't had a bleed on the brain, it's a blockage, then aspirin is your biggest ally, or a variant of that. The other thing that we talk about alongside detection of an underlying cause for a stroke, blood pressure we talked about, is an irregular rhythm. So these opportunities where you do, say for example, your clinic, and also the drop-in sessions, is an opportunity to say, yeah, we'll have a blood pressure check, but perhaps we should have a pulse check as well. So for your vaccinations, we're talking about what we can do in Felixstowe. Are there drop-in opportunities to say at the local library, etc., where little stroke groups raise the awareness of importance of the lifestyle things, yes, but also the pulse checks, the blood pressure checks, and use those as an opportunity. Because we know that atrial fibrillation, which is an irregular heartbeat, is associated with the more severe strokes, the more disabling strokes, and perhaps the ones where people won't survive. And so being aggressive about detection and then prevention in the form of anticoagulation. So by anticoagulation I mean, for example, warfarin, but we now have a whole host of other medications like warfarin that are available perhaps with more convenience to taking anticoagulation than warfarin historically has provided. So that in itself, those two big things, managing blood pressure, people being on aspirin, people being detected for atrial fibrillation and starting anticoagulation, is our biggest opportunity really to reduce the incidence of stroke, but also allowing the resources that are out there to manage the current problem. Because I think what we recognise is that the incidence of stroke will go up. Now, can your volunteer group, your drop-in session manage with an increase in the demand, really? And if it can't, then you're going to have have people who aren't going to achieve their maximum potential, but also very disappointed and very low mood, depressed individual, and perhaps even leading to people dying from their stroke earlier than they would have done. So blood pressure management, detection of atrial fibrillation, and then lowering things like cholesterol. We know that medication itself, just by the nature of how it works and its relationship with other conditions, say for example reducing heart attacks and stroke, statins are very effective and will be our biggest ally in terms of a population-based prevention strategy of reducing stroke incidence. So for example, if you were taking this area, Felixstowe, you would definitely say that the one biggest difference to the area might be to start screen people for their risk of heart attacks and strokes, and then start them on a statin, and by the sheer fact of doing that, you would reduce incidence of stroke. And there's very good argument for doing that. Now, there is an argument for putting people on very high doses of statins, and it's trying to allay some of the fears and the associations people have with statins of the various side effects or adverse effects that might have. But that's a conversation to have with your GP, your pharmacist, and the pharmacist is a great resource for that. As you know, with being stroke survivors, you leave hospital with a list of drugs as long as your arm, and they're not always palatable. You know, you prescribe 10 drugs in the, 5 drugs in the morning. How do you manage that? Could you split the dose? Could you take them in the evening? How long do you need to take these for? So the ones I've described, the antiplatelets, the anticoagulation, the statins, are usually the lifelong treatments. The ones that are perhaps less likely to be lifelong are ones where there are modifiable lifestyle modifications. So, for example, nicotine replacement for people who smoke. So, encouraging smoking cessation with immediate effect, but also allowing some replacement of that drug, because it is a drug, it's an addiction, to reduce the withdrawal effects of it. For alcohol, we don't say stop alcohol altogether. We often say cut down gradually, because actually if you abstain from alcohol, having a high alcohol consumption perhaps, then there's a risk of potential seizures from that. So we often say do things gradually, make it part of your everyday life, a sustainable thing that's long term. The other very common area of preventative medication and medicalising, I suppose, the prevention is around the functional recovery and mood, and people's mood after a stroke. A big event like this, loss of independence, sometimes breakdowns of partnership, relationships, the inability to communicate with your group of your family, your friends, your social group, and losing that has a huge bearing. So there are some good studies that say that antidepressants, anxiolytics have a good impact on functional recovery. And so for those who have significant disability, anxiety, and I would say with communication difficulties, we often prescribe say, for example, an antidepressant, anxiolytic in the immediacy with a view to review at 3 months, 6 months and beyond. And that's where the review period has a huge part to play, reviewing medication, reviewing the opportunity to say, is it working for you? If it's not working for you, don't carry it. There's absolutely a number of times I hear people coming back to my clinic and saying, why are you still on this drug? Has anyone discussed it with you, why you're still on this drug? And people say, no, I have no idea why I'm still on it. And it's an opportunity to say, is it absolutely necessary? Could we think of a different way of doing it? So that was another area, really, is to think about mood, and then fatigue is another one. Now, fatigue isn't something that I medicate for. What we often do is try and understand people's potential for sleep. So are they sleeping well? Are they having enough restfulness at night? Is there anything impeding that? Is it a breathing difficulty at night? Might they have obstructive sleep apnea? Are they slightly overweight and obstructing their airway when they're in deep sleep? Do they need something to help that? Does it need to be positioning? Is it about their meal times, etc.? Is it about having an extra break during the daytime? We don't tend to medicate for that. I have in a couple of patients where they've been very low in terms of their get up and go because of the location of the stroke. Well, we have tried the equivalent of an amphetamine, so a real sort of get up and go. They've used that in MS patients and in various trials that have happened with MS patients. They've then transferred to see whether the same would be the same effect on stroke patients. Pain is another one. Pain and prevention. Pain increases blood pressure. Pain disturbs sleep. Pain reduces your mood. it causes a lot of anxiety. So you can quickly see that pain becomes a problem as well. So prevention in terms of spasticity, pain, whether it be due to the location of the stroke, say for example a thalamic stroke, is often associated with a burning type pain. Burning type pain that's so discomforting that it's there all the time. It's there with you all the day. So we use sort of neuropathic agents to manage that kind of pain that hopefully reduce anxiety levels, hopefully lowers blood pressure, hopefully reduces the risk of another stroke. And the spasticity element of it, we've got other adjuncts. Most of it is therapy, and this is where I would say that access to ongoing therapy, short-term, long-term, beyond what the whatever the NHS can provide. And it's often carers who prevent stroke patients developing those complications. The spasticity that we talk about, the sort of classic pose that you see with a stroke patient, is the upper limb flexing, the lower limb being in that extension position, and that's why you often see the classic gait associated with a stroke, where the leg has to come out and around, a sort of semicircle out and around, because it can't quite manage the bending at the knee and the extension at the knee, and then the arm sort of assuming a flex posture all the time. So that careful attention to upper limb function, stretching it out, preventing that spasticity, and trying to avoid having to take medication. But the other medication that we do prescribe is for spasticity. You may have heard of it as baclofen or perhaps tizanidine. And sometimes we Botox injection, so botulinum toxin, which is a paralytic, and historically was used for very many other reasons and still is used cosmetically for many other reasons.
Doctor, can I just slow you down a little bit? I'm very conscious that you need to be back, don't you? So I don't know whether we could have a quick question and answer section.
Absolutely.
So, I mean, we've got 4 areas, how to reduce, when you have one, next steps after it, but I think what's been of particular interest here today is supporting a survivor to have as good a quality of life as that is as possible. So I don't know whether you'd like to lead in across the way, and then we'll go around the circle and see any of those particular issues that you'd like to raise. I mean, I want to know when we're going to have something so I can start eating grapefruit again, but that's a purely whatever. So I don't know whether there's anything specific that's been discussed that either impacts on you or you'd want further information on.
I think it's getting peer support. It's the peer group support, and I think also it's the inclusivity, because in all of this, the carer, they're the ones who are having to fight, and I think that the carer is the one who sort of misses the boat from the support. You suddenly land in this place and you sacrifice so much because you have to, because that's what you do for your other half to make it. And it's trying to get the support, because a lot of it you're fighting blind because you haven't got a clue.
So are you saying really that it's community health that should be doing this rather than the hospital setting?
There are things that are really good. The drop-in centre at the hospital is fantastic, because as well as people going and have their blood pressure, you get the carer come along and you get this. Yeah. And that's what a lot of it is about, is communication, is talking, it's finding out. You learn so much from talking to other people, and it's creating the forums for this. And the hospital, that wasn't in existence when we went down, that most probably when you were going through, there wasn't a drop-in. And it's one of...
So is that actually a bridge? Is that a link?
I think it's a brilliant thing, because it's an introduction, because that's where you can find out what's out there. Whereas when we went through the stroke, we weren't even told about the Stroke Association whilst we were in the hospital. It was something that happened through Icanhoe, and that's what started for us to get some support and some input. And I think considering the restraints that there are within the NHS at the moment, they really are fighting, and I think it's little things like this that create that forum. also from the tragedy is, and one of the frustrations from stroke, is that no two strokes are the same. So you cannot mentor your progress by looking at Mrs. Jones down the road because she had a stroke 3 years ago and she's now doing this. It doesn't work like that. Everybody is an individual, and that's one of the first lessons we all have to learn, both a survivor and carer. But it's having those things where you can talk to people, it's having that opportunity to learn. And also to think, I'm not alone.
He won't give you that.
So is there something specific you'd like to ask to
No,
Dr.
I think
Chowdhury?
I totally agree with
I
that.
think there's drop-in clinics, one opportunity, and perhaps spreading. I think what has been tried in the past is the sort of patient passport as an opportunity to pass on information, signpost, and allow people to call back. That, with the number of moves and the opportunities to get lost, is a problem. And I think the drop-in clinic is largely sort of based on carers sort of remembering when it is an opportunity and sort of an open door.
I mean, I went to it for the first time last week, and I had my stroke, the detectable second and then the third after that, about 2 years ago. And by that time, the stroke backup facility at Ipswich was, I don't know whether it's second to none, but I was very impressed. I didn't even know I'd had a stroke until I went to sign a cheque, and it could have been the shock of having to sign a cheque that did it. I don't know. I couldn't write, and my daughter, who's a vet, said, I'm making an appointment for you at this surgery, because I was at Hadley at the time, and they came here, they gave me the double dose of aspirin, they got me in on the emergency assessment the next day, and by 3 o'clock I was sat in front of a consultant who said, most people that come here, they don't have this news, but unfortunately you've had a stroke. And that was very quick, talking to somebody in the church. She had a stroke, they rushed her to Ipswich, put her to bed, and then really did nothing but waited for the next one to come. And sadly it did, as you said. If you don't intervene with the first one, the odds are you'll get a second one, which might be even bigger. And in her case, she did. You know, I was impressed.
They get you down to a scan.
Yeah, I mean, there's nationally, I mean,
The
there's
standard's better.
a standard of care that we adhere to. I think now with the opportunity of trying to treat a small, as you say, all strokes different, but a proportion of the strokes that we historically treated with a clot busting drug, now there's an opportunity to try and remove that clot. And that requires an additional scan, but also urgent transfer to Addenbrooke's for equivalence of surgery. Now, it's not for everyone, it's probably proportionally about 2% of all our strokes. So in any given year, we look after 600 stroke victims a year at the Ipswich Hospital, and so you're looking at between 10 and 15 of those individuals benefiting from potentially a transfer to Addenbrooke's. Now that's a scary thing given what you said about seeing the ambulance go by, but I think it's so long as the message gets out there that the treatment hopefully will improve the outcome and allow that opportunity for them to return with less disability. Otherwise, sometimes we're in a position where we are dependent on all the rest of it. And what I suppose about my opportunity is preventing it. So yes, you've had one, maybe perhaps what's regarded as a minor stroke because you walked in and you've walked out the same day, compared to someone who spends 3 or 4 months in the hospital and then spends the next 3-4 years or the rest of their life sort of trying to rebuild from that. So I think that's the opportunity going the next 10 years ahead, because I mean there is an idea that we should be thrombolyzing, giving a clot busting drug to anything between 15 and 20% of stroke victims. We see about 25% of bleeds and 75% of clots. And so you're thinking that if everyone rang as soon as they had symptoms, then about 20% of those we should be able to give clot busting drug treatment to, and a proportion of those might benefit from the clot being taken out. Now that would potentially reduce the disability significantly, because the numbers needed to treat for clot busting treatment is 8, so you treat 8 individuals and you have 1 individual who makes full recovery within sort of 3 months. And then for the clot extraction, you're looking at only 3 people to treat to get 1 person back from the point of where they might have life-change disability to being independent at 3 months. So the opportunity is potentially massive. It's just getting that word out to call for help urgently as soon as you feel something's coming on, to then access that, in addition to all the other things that we've talked about, which is the lifestyle and the preventative strategy. And I think mental strength is a massive opportunity, sort of to keep going, to keep going, to keep going. So the carer support, so I was going to say the Suffolk family carers at the hospital is in addition to the drop-in clinic that we've now, Dr. Jameson's kind of brought into the ward, the Suffolk family carers to be introduced to the carer on the ward. And then Stroke Association, I think data collection and data sharing has been always the limitation to this. So if we said that every stroke patient who comes in, you know, the opportunity to have that information forwarded to the Stroke Association, and for there to be a trigger to say, yeah, they're going home, or there's an opportunity for you to contact them, then we miss that partly because of we have to ask consent, etc., etc., etc. But and I think in the busyness of sometimes of how quickly we get through, you know, our turnover of acute beds, sometimes you have 2 people in the same bed within a 24-hour period. That's partly where my experience of the stroke passport used to get lost. I used to sometimes come onto the stroke unit at St Thomas's and find that there was a passport belonging to someone who'd been there the day before, but you know, having filled it in diligently, given it to the patient, that just in the whole turnover of everything, you know, the paperwork's got dispersed. So I think an opportunity, specifically with communication difficulties and the gap we have with communication difficulties in Suffolk and nationally, that the Stroke Association fills a big gap. Elaine, and I know your experience, Elaine, probably highlights that your interactions with people in and around this area, when I'm in this area, the east of Suffolk, if there's communication difficulties, there's a huge gap. Now, how do you then access that and hear about it if, you know, if someone in your parish says there's this person with communication difficulties, they might need your support. How do we allow you to get your communication in and allow that individual to get their work, you know, communication out? The opportunity to have, there's a skill, isn't there, in that kind of communication, and I know from my experience of the speech therapists on the ward, Connect, meeting people like yourself 6 months after, a year after the event, that time is a huge thing for the communication side of things. And whereas the physical recovery, the walking, you know, being able to manage your own wash and dress, that's one aspect, but then being able to communicate is a huge, and time is a huge thing. Singing, I think, is a massive thing. How do we access that? So I think there is an opportunity to groups, and like you've done with Mildenhall, I think that's probably the way forward, where there's a demand. But then, how do you measure the demand? Is the next question. Is how do you do that? I think we have the opportunity. We've got data. We've got so much data that if you wanted to equipment that improves cardiovascular fitness.
Right.
I think it's also about what you're used to and what's comfortable for you. Now, accessing that in the community now is harder, and I think that's probably where practices like this, the bigger combined practices, the local leisure centre, the public health, the local council now being in charge of public health, people like One Life Suffolk really come into play,
Right.
because that will tailor an individual thing rather
So
than a one size fits all.
So walking football for the over whatever, it might be
Yeah.
a good team to join.
Yeah, and I think it's that mental well-being, whatever that brings with it.
Yeah.
Yeah. Part of parish nursing, we run a chair-based exercise class as well. We've got 2 classes that we run once a week. They come to that, and we did have a lady there that her recovery from stroke was so improved by coming to the chair-based exercise. Just the balancing and things, you know, when
Yes.
she first arrived, getting out of the chair and getting up again was so
Dangerous.
difficult. But several weeks later, she was doing it. So it was such a success story post-stroke for her through chair-based exercise, and you know, things
Doesn't
like
seem
that.
much, does it?
No,
It really doesn't.
but
No.
the resistance, I've done it. It's quite
Yeah.
extreme.
And there's a lot of
actually.
time when nothing happens on the stroke unit,
Yeah.
and I think that's recognises that a lot of things like that, or little group or repetition,
Yeah,
can
so
make a huge
valuable.
difference. And so it might be useful for the carers to say, look, this is your programme of
Yeah.
exercise you could be getting on with while I
It's
go and do
everyone's
something else, or
thing.
you know, and
Doing
then
some at home.
and
Yeah.
do some at home, or do you talk about sailing, and Headway have organised that, but also down at Alton Waters they have a disability group that allows the sailing down there. Talk about Levington, so. But that is dependent on people like yourselves, the carers, making that phone call
Well,
and
I think when
accessing
you leave
it.
the hospital, this is my idea, I think you should have more paperwork so you
Yeah.
can go through
Connect.
it.
So yeah,
Yeah,
an information pack really, or,
Yes.
or something.
because there wasn't enough.
No.
I used what there was, but there wasn't enough. Because I didn't know where to begin, to be quite honest with you.
I almost think there's almost like
Need a
like
community link.
a community link, a hotline to just pick up the phone. Now, the Stroke Association are probably our sort of most generic for that, and then to be able to have that opportunity, as you said, you've got the folder of contacts.
I think it depends on the person. If you're the sort of person that can take all that information at the outset, because when you go into hospital, you're in a crisis. You're in such a
Yeah.
panic. You've got the person who's very, very poorly, and you're just trying to cope with that situation as it happens. But then there are some people who can, at that point, they're on hyper, they're at that crisis energy is meaning that they can take in everything. They are going to write down everything that's happening. They're going to take lots of phone numbers, names, times. That preps them to do all of that information gathering.
Right.
But then there's other people that just flounder and can't do any of it, and they can't pick up all those pieces of paper. All they can do is take their loved one home.
Yeah. But I think what you're emphasising, and that is supporting a stroke survivor, is Tony is only here fit talking today because of what you did. And had you not done it, he would have, in my day, he would have been, or when I was a child or a young person, he would have been in a bed for several months, and then pneumonia would have come along and he would have departed. Because that's what used to happen, didn't it? And we really moved on in a major way, it seems to me, in 5 or 6 years. I don't know whether you had a lot
It's the
more
last 10 years,
funding.
I mean, it's the stroke. It's the idea of having a designated stroke unit. By the mere fact that you go to A&E, you have your scan, you're seen by a stroke nurse, and you're admitted to a unit which recognises the potential complications, which is the pneumonia, which is the swallowing difficulty, which is the positioning, which is the fall that prevents preventing a fall that leads to a hip fracture, which then leads to your demise. So I think the change that you describe is because of a national recognition that there's a need for a stroke unit rather than people being spread around the hospital, and therapists coming at a time 2 days later, 3 days later, when they found, oh yeah, there's a stroke on that ward.
A bit late.
So
It's too late.
that's what happened.
Speed.
That's what used to happen,
Yeah.
and it used to happen to all age groups. And now you were describing the quick referral system. That part of the reason we're finding more younger people with strokes is because of that increased awareness and that access to imaging and confirmation of stroke. Now, why younger population are having more strokes is another matter, and we'll find out in the next 5 years or 10 years why that is. But there is a sort of commonality, which is again lifestyle choices, whether it be obesity or whether it be a lack of cardiovascular fitness. But we need to investigate, and we investigate a lot more why people have strokes than we did before. So there was a lot more of, you've had a CT scan, you've had a stroke, you have your rehabilitation, here's an aspirin and that's it.
Off you go.
But there is a lot more investigation as to why it happened. And younger patients often have more anxiety than the older patients. So I often say to the younger patient, the 40-year-old, the 30-year-old, who has no physical disability, but they carry a lot of mental baggage with them, because they're terrified that next time they step into the shower, which is where they had the stroke last time, is they're going to have another stroke.
Strange you should say that.
And despite putting them on medication, despite putting them on, reassuring them that actually everything's been done possible to reduce that risk. Whereas the individual who has the disability down one side, perhaps the speech isn't as fluent, might be, return home with an acceptance of that, but with a determination to rehabilitate and go forward with their lives. It's an interesting difference between the age groups.
Is there any more questions from the floor?
When you said about the atrial fibrillation, we had a meeting on Monday with the other parish nurses in the area, and she was allowed to trial the little gadget, two-finger.
The live core.
Yeah, I mean, would that be helpful to you if, as parish nurses, did that? When
Yes,
we were doing our
absolutely.
clinics? I
Every
mean, I don't know
opportunity.
how
I mean, the
access
practice
those.
here, Dr. Feltwell and others have been offered the opportunity by the Eastern Academic Health Science Network
Right.
to access these live core devices. So that's the brand name of a device that fits to a mobile phone.
Yeah.
You put your two thumbs on the device, hold it for a number of seconds, and it gives you a readout as to whether your heart rate is irregular or regular. It really is a sort of black and white. It's not telling you whether you've had a heart attack before, whether you're impending heart attack, whether your heart pauses or anything like that. It literally is just, is it regular, is it irregular, with the idea that if it's regarded as irregular, it's shown to a healthcare professional who then will counsel you about the opportunities to reduce risk.
Could I share with you just one thing that was a benefit of having a stroke, because there aren't many, but this was one. I found after I had my third one that the scans were all collected, and if you wished, you could go and get a CD copy of your scans. So now when people say to me, you're brainless, Nimi, I can say, no, I'm not. I've got some hose, but there's my brain. So that's sort of the only single thing that I can think of that it might be good because you've got a copy of your scan.
Yeah, you can all access your scans. I mean, there's
Yeah.
this vast library of images. And I think, as you said, Terry, everyone's different. I think if you hear survivor stories, part of me, in terms of understanding some of their recovery, I try and imagine I'm always thinking about the timescale for the recovery, the kind of recovery, and who they've had to support them. But also I'm thinking about what type of stroke they had. Hemorrhages tend to take the initial period of concern around a hemorrhage is partly because you see very little in the way of progress in the first few days, in the first few weeks, because you're waiting for the blood to disappear. It's like a bruise, and you're waiting for that to disperse. So we're often waiting 4 weeks to 6 weeks to try and understand what damage is underlying a bleed. Whereas with a clot, immediately you're seeing that weakness down one side, perhaps the brain swelling because it's such a large stroke, contributing to a lower level of consciousness. Perhaps in your case, as you're in sort of the cardiac situation, that very severe type of stroke that requires 24 hours, 48 hours to see the worst of the disability, and then you're starting from there. So, and then things like subarachnoid hemorrhages, which is how quickly did you get to Addenbrooke's, how quickly did you have the clip put in, how much damage was there done during the time of that initial bleed, and how long were you in a coma, did you have a pneumonia during the coma, did you have a catheter in, and did they delay in getting that out? So, and also
Speed
now
seems
with
to
the
be-
age of our patients, and yes, people are having one stroke, perhaps having and going into hospital for other reasons. Delirium, so if you've got brain injury, the propensity for other complications like seizures, also cognitive impairments, so your threshold for new medication and infection to lower your threshold to developing something like a delirium, a confusional state. So I had an example recently where someone who I'd seen a year ago with a communication difficulty, an aphasia, the community nurse, it's a social worker, and her friends were concerned because she was less communicative at her badminton sessions. Now, was she having a new stroke, or is that part of something else? Now, that's where the advantage of us reviewing that individual, having access to MRI, is quite helpful, because I can then say, okay, we'll do an MRI. I've seen the injury. I think it's fairly similar to when I last saw her, that the MRI doesn't show any new stroke. So this is either a deconditioning. Are there other things going on? You know, is she taking medication? Is it because she's got a urinary tract infection? Other things. So we have to then tackle those things. And especially with communication, where that individual had lost their spouse, that person's just by themselves, and the friends are very supportive, but the community needs to rally, and the social worker, and understanding the legal aspect of making decisions based on someone not having the ability to express themselves and their best interests sometimes, that you might be depriving someone of their liberty if you make those decisions on their behalf. So it is such a broad spectrum, and I think communication and sometimes the brain injury itself, lowering your threshold to other complications such as delirium in the event of an infection, in the event of starting new medication, having a seizure, etc., is a problem. So, and just understanding that.
So what happens for people who have a stroke, who don't actually have any family carers? Who actually speaks up and gets the level of support that has been given by
So
here?
I think
Is it
what our
social
speech-
services? Or?
Yeah, so I think speech and language therapists and the stroke team try and do everything possible to use what we call total communication to try and access that person's understanding and that opportunity for them to try and communicate. In the absence of that, obviously, then we have a social worker, and we have to refer for what we call a deprivation of liberty safeguarding,
Right.
which is an acceptance that beyond 7 days of acute treatment, that we can continue to offer treatment and advice for someone who is no longer able to
Make a decision.
Thank you.
make a decision.
Thank you for coming. That was very kind. And we'll see you later. Keep up the good work.
So that's safeguarding through the community
Good.
and the social worker. Adrian, were you going to say?
Sorry, yes. Sorry, I was spitting.
I had a seizure, but I had a seizure after 12 months. So, you know, that's...
It was very, very interesting, wasn't it? Because I know when you were in hospital, when we were actually approving, they would ask the question every day, has he had a seizure? Because they were expecting it, and they really were expecting it. You had a seizure, you had 2 seizures with it.
Hi, welcome to the Bartlett Room at the Grove Medical Centre. The PPG, of which I'm a member, arranged a stroke information session here today, 25th September. The attendance during the course of the day actually indicates that those who are at risk of having or recovering or supporting a stroke survivor, it would appear fully informed and supported. And the good news for this particular surgery, the Grove budget is certainly not needed to be spent, it would appear, on information for those who have suffered or may be suffering for a stroke. During the session, we shared the actual experiences of 2 stroke survivors, very informative. What it seemed to indicate is the degree of recovery and survival is very much related to the amount of effort, blood, sweat and tears the either partner or family of the stroke victim are able to put in and work often quite tirelessly on their behalf. We did have a representative from WALTON Parish Nursing drop in to join the session, and that gave the whole thing very much a local flavour. And at the end of that, Dr. CHOWDHURY from the stroke unit at Ipswich Hospital responded to a lot of the issues raised, gave a lot of information about causes of and how to avoid. Certainly blood pressure, diet, exercise came out as key things to be looking at, to be doing. That was also picked up by WALTON Parish nurses, and that they often, in their public meetings, which they have 2 or 3 times a year, do blood pressure testing as a matter of course, so that seems to be something you should be looking at. Anyway, don't listen to me anymore, take a flavour of the sessions themselves. We'll kick off with Tony, starting off the whole session. Okay, see you again on another health information day. Bye for now.